We are on live. We are good to go.
Thank you. Good evening, doctors. Welcome to this webinar on experience sharing program on managing PPH, case studies from labor room. Doctor, this program is brought to you by Heathrow Healthcare, an innovative pharmaceutical company. Heathrow Healthcare, the journey began in 1993 and we have got 25 years of excellence with 36 state-of-art manufacturing facilities and 300 plus products in portfolio. Heathrow Healthcare has presence in 126 plus countries and has 21,000 employees globally. Heathrow Healthcare is the largest closely held pharmaceutical company in India and is among the largest manufacturers of ARV, APIs and FDFs in the world. Heathrow Healthcare is has Asia's largest API manufacturing facility at Visakhapatnam, Andhra Pradesh. Heathrow Healthcare is a 360-degree solution provider striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties, pioneering in quality and innovation, and has the distinction of bringing 4 biosimilar products to market within 5 years of initiation. Today's webinar, Experience Sharing Program on Managing PPH. We have got Honorable Speaker Dr. Varun Shah with us. Welcome, Dr. Varun Shah.
Thank you.
Dr. Varun Shah has got his MBBS DNB DGO with Diploma in Advanced Gynec Endoscopy from France, Fellowship in Reproductive Medicine ICGOG, Director and Chief Consultant in Inception Super Specialty Women's Healthcare Borivali, Infertility Specialist Endoscopist and Urogynecologist. With this brief introduction, I hand over the session to Dr. Varun Shah. Over to you, sir.
Yeah, thank you. Can we go on the slides, please?
Yes, sir.
Yeah. Can we go on the first slide? Yeah. So today we are going to talk about postpartum hemorrhage, which is one of the most common, I would say, but still most difficult to manage event which happens during the labor process. And still in India, it's one of the leading cause of maternal mortality. And we are still figuring out how to manage it and how to manage it effectively. And there are various ways and means which are available to manage PPH, ranging from detecting it to preventing it to then actually managing it. So today we are going to talk about few of those aspects. So by definition, PPH is loss of at least 500 ml of blood following vaginal delivery and then 1000 ml of blood following cesarean section. It is common and can occur even in women who are not at risk, which is the most important point. PPH is the leading cause of maternal mortality in low-income countries like India, and it's a primary cause of nearly 1/4 of all maternal death globally. Next, please. So it is an unfortunate event, but it is still common, as already mentioned in previous slide, that it is one of the leading cause of maternal mortality worldwide. In developing countries, it was 240 per 1 lakh female, 1 lakh live birth, compared to 16 per 1 lakh live birth in developed countries. Global PPH incidence is 14 million women suffer from PPH. Incidence of PPH reported as 2 to 4% after vaginal delivery and 6% after cesarean section. PPH incidences in India, 38% of maternal deaths are due to PPH, 25.7% global deaths of this attribute to PPH. India has an unexpectedly large number of maternal deaths, which is 540 per 1 lakh live birth. Next. This is the etiology of postpartum hemorrhage. So main etiology is so there are basically two parts of PPH. One is called atonic PPH and another one is called traumatic PPH. But mainly it is tone, which is the uterine atony, inability of the uterus to contract, which may lead to continuous bleeding. there is a smaller percentage of female would have coagulation failure. Trauma is another reason, which is trauma to the blood vessel or extension of the scars or rupture of the uterus, etc., which is one of the cause, and retention of the placenta is one of the cause. Next, what are the clinical findings in PPH? So, there is an abdominal tenderness, circulatory collapse, increasing abdominal girth, loss of uterine contraction, maternal tachycardia, and vaginal bleeding. Clinical finding. So if blood loss is between 500 to 500 ml to 1000 ml, there is a 10 to 15% of the blood loss, which is a compensation phase. There are no blood pressure changes, and there are symptoms like palpitation, dizziness, and tachycardia. In the mild degree, the blood loss is 1000 to 1500 ml. The BP may slightly fall. It leads to weakness, sweating, and tachycardia. In the moderate category, the blood loss is 1500 to 2000 ml. There is a marked fall in BP, and there is a restlessness, pallor, and oliguria. In the severe cases, there is a 2000 to 3000 ml blood loss, is a profound fall in the blood pressure, collapse, air hunger, and anemia. Next. So these are the algorithm towards the PPH. Uh, so there is one thing, as we already discussed, which is related to the tone of the uterus. And it says that when there is a clinical finding of abdominal palpation, the uterus feels relaxed, boggy, and soft. And uterine fundus may be felt above the umbilicus if the uterus cavity is filled with blood and clots. The investigation which required is full blood count, coagulation profile, urea, and electrolytes. If the patient is not responsive to fluid and blood replacement, abdominal ultrasound is required to exclude uterine rupture or intraperitoneal bleeding. Management: uterotonic agent like oxytocin, prostaglandin, and ergot alkaloids, and uterine blood balloon tamponade. Hemostasis algorithm is also followed. Then comes the traumatic PPH. Clinical findings are from areas of trauma within the genital tract. It can be uterine rupture, or it can be extension of the uterine angles, tears during the cesarean section, extragenital causes such as subcapsular live rupture of ovarian or splenic vessels. The inspection during the cesarean section by exteriorization of the uterus, ultrasound may help to identify free fluid in the peritoneal cavity with uterine rupture. Management is the repair of the identified genital tract trauma. Pelvic arterial embolization may be required in cases of broad ligament or supraalveolar hematoma. Retained tissue, the clinical finding retained placenta membranes identified during the bimanual examination under anesthesia, management, manual removal of placenta or retained products of conception under anesthesia. Coagulopathy, clinical findings are continuous bleeding, contracted uterus, uh, investigation, urea electrolytes, fluid blood count, and coagulation profiles. Management is the medical, immediate replacement of the blood and coagulation factor and placenta. Surgical only with trauma or atonic hemorrhage and unresponsive to medical treatment. Next slide, please. So, what was the rationale for development of the carbetocin in the new heat stable formulation? Carbetocin is available in the room temperature stable formulation and convenient vial presentation. Oxytocin and ergot alkaloid should be kept in refrigerator to avoid degradation. Heat stable formulation of oxytocin is currently not available. Previous formulation of carbetocin should be stored within 2 to 8 degrees Celsius. Resource poor countries do not always have a refrigeration place. facility. So we needed something which is stable at room temperature, has shelf life more than 24 hours, 24 months at 30 degrees Celsius and 75% humidity, and avoid need for cold chain storage and logistic, and it's provided in vial. Next. So use of uterotonic agents at the time of administration, at the time of crowning of the baby's head, at the delivery of the anterior shoulder, at the end of the second stage of the labor, following the delivery of the placenta. Prophylactic use, prevention of PPH, active management of third stage of labor, and therapeutic use, management of PPH. Molecules available are oxytocin, carbetocin, ergometrin, synmetrin, symptometrin, and misoprostol. Next. So, what is a carbetocin, which is a next generation drug for PPH management, which is a synthetic long-acting analog of oxytocin. Therapeutic indication are prevention of postpartum hemorrhage due to uterine atony. Posology and administration, 1 ml may contain 100 microgram of inject carbetocin in 1 ml solution injection. Carbetocin was created by making several modifications to the oxytocin structure, which prolongs its half-life and reduces the enzymatic degradation. Next. So, main characteristic difference between oxytocin and heat stable carbetocin is that oxytocin is a synthetic cyclic peptide from the naturally occurring posterior pituitary hormone. It binds to oxytocin receptor in the uterine myometrium, stimulating contraction of the uterine smooth muscle by increasing the sodium permeability of the uterine myofibrils. While carbetocin is a long-acting synthetic analog of oxytocin. It also binds to oxytocin receptor in the myometrial muscle, resulting in rhythmic contraction and increased frequency of existing contraction and increased uterine tone. Pharmacokinetic, IV administration, immediate action within peak concentration after 30 minutes. Intramuscular, slower onset of action, take it 3 to 7 minutes, but produce a longer lasting clinical effect up to 60 minutes. Half-life is around 1 to 6 minutes. While carbetocin sustained uterine contraction within 2 minutes, lasting for about 6 minutes, followed by rhythmic contraction for 60 minutes. Once it is given IM, sustained uterine contractions lasting for 11 minutes and rhythmic contraction for up to 120 minutes. Half-life is 40 minutes. Storage and transfer. So oxytocin requires protection from the light and storage 2 to 8 degrees Celsius continuously to preserve its activity, while carbetocin can be stored at 30 degrees Celsius. Clinical indication, oxytocin and heat stable carbetocin. Induction of labor can be used, it cannot be used. Augmentation, yes, no. Prevention of PPH, yes, yes. Treatment of PPH, yes and no. Next. So clinical evidence is carbetocin is non-inferior to oxytocin. WHO champion trial. Champion trial was carbetocin hemorrhage prevention trial, the largest clinical trial in the prevention of the PPH. It was done by WHO study design, non-inferiorly double-blind randomized trial. Objective is to compare the effectiveness and the safety of the investigational heat-stable carbetocin to oxytocin in the prevention of PPH after vaginal birth. Patient enrolled 30,000 women across 10 countries, including India. Primary outcome, the proportion of the women with blood loss at least 500 ml or the use of additional uterotonic agent. The proportion of the women with blood loss of at least 1,000 ml. Next. The parameter were efficacy, carbetocin, blood loss more than 500, 14.5%, and oxytocin 14.4%. Blood loss more than 1,000, 1.5%, carbetocin 1.45%, safety 4.9% versus 4.7%, at least one serious 0.7%, 0.7. The frequency of blood loss of at least 500 ml or use of additional uterotonic agents with carbetocin was proven to be non-inferior to oxytocin. The use of additional uterotonic agent intervention to stop bleeding and adverse effect of not differ significantly between two groups. Conclusion: Carbetocin was non-inferior to oxytocin for the prevention of blood loss, at least 500 ml, or the use of additional uterotonic agents. Next. Cochrane review. So, carbetocin for prevention of PPH. In this review, 11 studies involving 2635 women were included. The author concluded that the women who undergo cesarean section, carbetocin resulted in a statistically significant reduction in the need for therapeutic uterotonics compared to oxytocin also. Also, carbetocin is associated with less blood loss compared to symptometrin in the prevention of PPH for women who have vaginal deliveries and is associated with significantly fewer adverse effects. Next. Guidelines. So, recommending body is WHO, and the guidelines for PPH is only one of the following. It is for the prophylaxis. It is either oxytocin, carbetocin, misoprostol, ergometrin, or methylergometrin, oxytocin, and ergometrin fixed dose combination. SOGC Canada, carbetocin 100 milligram microgram IV bolus. Renzo, New Zealand, active management of third stage labor, prophylactic uterotonics. Figo, carbetocin, one of the recommendation for PPH management. Germany, Austria, Swiss body, 100 micrograms slowly, carbetocin IV. FCOG, carbetocin on proving non-inferiority to oxytocin, achieved by champion trial. Next. My experience with carbetocin, smarter, superior, and safer choice in PPH management.
Sir, since when are you using carbetocin? How long?
More than 3 years.
And which is the form you generally use, IV or IM?
IV.
Do you use it in all patients or you use selectively?
All
All
patients.
patients. So coming to this, some of the questions that we have received.
Yes.
What is the benefit of using carbetocin as a first-line drug in preventing PPH?
The most important benefit is the easy administration. And as trials also suggested that it is more useful in prophylactic use in cesarean section. So I use more likely in cesarean section, and it is a longer effect, and it's a heat staple component drug. So all these things are useful. So that's why it is, and the effect is similar to oxytocin. So that's why it is a first line therapy.
First-line drug. Although we can anticipate PPH in each and every patient, there are some few patients who are likely to get PPH. No? Which are those patients?
So
Patient
number
profile.
one is the anemia. Number two is the blood pressures, which is gestational hypertension or preeclampsia. Number three is twin pregnancy. Number four is polyhydramnios. Number five is prolonged labor. Number six is uh, uh, too much use of induction drugs during the labor. And number five is difficult C-section or the impacted head, where we had to do a lot of jugularity to remove the head. So these are generally the patient profile where you can anticipate.
Thanks, sir. It's a very elaborate and comprehensive. Thank you so much. And any experience of use of carbetocin in Rh negative mothers, sir?
Yes, we can.
Now, this is very common because oxytocin is used for labor induction very commonly. In such a scenario, can a doctor use carbetocin for prevention of PPH?
See, one has to understand that if the oxytocin is already on the go,
Hmm.
you cannot use carbetocin because both of them are utilizing the same receptor. So if you want to use carbetocin, try to stop oxytocin at least 30 minutes prior. And
Okay,
then you can use carbetocin. Otherwise, there will be zero effect. It is important to understand that carbetocin is not superior to oxytocin, it is non-inferior to oxytocin.
correct.
That means that if you are using oxytocin, you can just continue using oxytocin as a active management of the third stage of the labor or to prevention of the postpartum. There is no need to use carbetocin as a separate entity.
Yeah, correct. You can continue with the same because both of them would be ultimately acting on the same receptors. So, have you experienced any ADH related side effects with oxytocin anytime?
Yes, we have. We have. Not in my
Ye-
clinical setup, but when we were in a residency.
Yeah.
So there was a patient who underwent the second trimester termination of the pregnancy, and uh, for with whatever efforts we could give, she did not go into a proper labor, and she
Okay.
received a very large dose of oxytocin, and
Oxytocin.
she had ADHD by
ADH
the
is
way.
in there. So rare, although it's there, it's rare, very rare. IV route is the route that you follow, but then is there a place for IM route?
See, I in my clinical setup, we prefer IV
Prefer
route,
IV route. That's
so
perfect.
there is no question.
How do you feel carbetocin is tolerated?
It's very well tolerated. I have not seen any side effect with that.
Excellent, excellent. That's a great thing because PPH itself is a troublesome thing, and to
Yeah.
add to that, if carbetocin gives adverse effects, if suppose the patient is not responding adequately with carbetocin, then in the order of preference, which additional uterotonics would you use?
My first preference is if the patient's blood pressure is normal, then it is to use
Methotrexate.
methyl ergometrin.
Yeah.
And then, along with methyl ergometrin, we always use either uh, misoprostol or PGF2 alpha. So that is,
Carbetocin.
yeah, carbopros.
So preference is always for methergine or methyl ergometrin.
Yeah,
In my time, during those times, we had only oxytocin and methyl ergometrin. I mean, we
correct,
had a lot of trouble at that time.
correct. Methogen is a fantastic drug.
Yes, 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 yes. What are the advantages of carbetocin over other uterine? I mean, you have discussed this. Should carbetocin be kept as a reserve drug or should be used as a first line?
I think it is no-brainer now that can be
Yeah,
used
yeah,
as a
it is.
first.
People are using it as a first line. And to conclude, what is your overall take-home message for the audience?
Uh, you my take home is very simple. They do not rely on only one proteinectomic agent. Always be very, very cautious when you are
Absolutely,
delivering even the low risk patients because
absolutely,
PPH can happen to anyone at any given point of time.
absolutely,
And keep your team ready for the management of PPH.
absolutely. I mean, that's very correct because expect the unexpected is what can happen.
Yes.
Thank you so much, sir. I mean, it was great
Thank
listening to
you.
your answers. In fact, it's a practical experience which our doctors want rather than reading theoretical literature. Thanks so much for
Absolutely.
sharing your experience. And thanks for
Okay.
taking time on this evening practice for this. And
Thank
thanks
you.
all the doctor who took time and attended this webinar. Thank you, marketing sales team of Hitro. And thank you, IT team, for your IT support. Sir, you can sign off, sir. Thank you so
Thank
much.
you. Thank you.
Thank you. It was a pleasure having you.
Yes.
Yeah. Thanks, Bhuvan. Thanks, Vivas.
Thank you, sir.
Thank you.